Sex Talk with the Siegel Brothers is a weekly program designed to answer all your questions, including the ones you didn't even know you had, and to clarify the endless debates around the wonderful and fascinating world of sexuality. Join us for real talk about sex from two experts in the field. Richard and Larry Siegel have over 50 years of experience as sex therapists, educators, counselors, and researchers. The Siegel brothers are recognized around the world as trainers of medical and mental health professionals.
Hello and welcome to Sex Talk with the Siegel Brothers. I am Larry Siegel, a clinical sexologist and certified sexuality educator.
And I'm Dr. Ricky Siegel, a certified sex therapist and supervisor.
And proud to say my brother.
Very proud.
Good to see you again.
Good to see you.
Cheers to you, my brother, and cheers to you all for joining us.
My ritual sake toast. Tonight we have lychee, my favorite. Thank you very much.
I got it. Such a nice taste. So
good
smooth.
to be here with you, my
Same
brother.
Same here.
And good to be here with you.
Indeed. And if you're joining us
viewers.
here on YouTube, please hit that like button.
Subscribe to our channel.
Indeed. And let us hear from you. Drop some comments in there. Questions, statements, comments, anything you want to see, anything you want to hear us talk about. Just say hi. That works too. So we'd love to hear from you.
And likes and shares on Facebook appreciated as well.
Indeed.
So this is our weekly opportunity to talk about sex, though, every day should be Sex Talk Day. There's never a shortage of things to talk about, or as sexuality educators like to say, never a shortage of teachable moments.
That's right.
Especially for those of you who are raising young ones. It's just really important that just like any other conversation you have about health and hygiene and growing up, it should be easy and matter of fact, and certainly not a one-time event.
Right, and that's the thing. I think that's why for so many people it's not easy, because they think it's a performance. It's something they have to do. It's some event.
The drum roll starts when they're about 9 or 10.
It's the way you should be living every day. If you are a parent, if you are in a relationship, this should be something you talk about all the time, but not like, again, talking about separately. It should be a normal part of everyday conversation.
Right. And as we used to kind of preach in our former sexuality educator days, the message is always about age and stage appropriate education, which means there are important things for 2 and 3 and 4-year-olds to know.
That's right.
And of course, really important things for what do they used to call them? Tweeners, right? Like young
11,
adolescents,
12.
pre-adolescents, teenagers. Certainly a ton of stuff that should be talked about. But a lot of people also, I think a lot of parents make the mistake of thinking that if you have done it, which of course far too parents have, but if you have done the job, that it ends when the kids go off to college, right? But of course, learning about sexuality, especially in relationships, is an ongoing part of life.
Indeed. And going off to college sometimes just adds a new chapter to that story that needs to be told.
Yeah.
I've had over the last couple of years for a number of people we know that they've asked me, I've put together, like a little packet of information for them to take to college with them, right? And because it's so necessary, survival.
That care kit. But even, adults in their 30s and 40s and 50s, people who've been in relationships, said it to couples in therapy so often that, I have to try and say it so it doesn't sound like I've said it a million times already. But a relationship is an ongoing process of learning about your own and each other's sexuality together. Right. And if you're not growing, the one thing I think sex therapists hear more than anything is that, that spark goes out. That
the magic is gone.
Yeah, and people need to grow together. Sexuality, we always say the honeymoon phase has to end. And what we have in store for tonight's discussion is part of that lifelong accepting changes and dealing with the changes that life brings, that even during times of illness, or accident or disability, sexuality still needs to be talked about.
In some cases, even more so. And again, you talk about how people don't address it under typical everyday circumstances.
Right.
When there's now illness, disability, certainly related to things like cancer, nobody wants to touch it.
Right. And we always complain about how most mental health professionals and medical professionals, even urologists and gynecologists, what most people think of as penis and vagina doctors, who should be able to answer questions about sexuality. There's no training there. Right. And yeah, as you said, when it comes to cancer, I remember fondly an ASECT presentation. It was an opening plenary. I'm pretty sure it was the conference in Pittsburgh. So I want to say way back in the yonder times, probably around 2000, 2001, 3, 4, sometime in the early aughts, when this Dutch physician, really cool name, I'll never forget it, Wout Gianatten. First he blew everyone's mind before he even spoke a word by putting up, remember he put up a blank slide with 2 words on it.
I do remember that. Yep.
Palliative sexology.
Yep.
And everybody in the room.
We all looked at each other.
600 sex therapists just went, like, why are those 2 words together? What is, and he talked about, even like at end of life, most people see palliative and they think of like hospice care, right? But medical care, again, during sickness and illness. But his most poignant quote of that plenary presentation was making the point to a room full of sex therapists and sexuality educators and counselors and researchers that oncologists are afraid to talk about sex, their patients are afraid to talk about sex, and sex therapists are afraid to talk about cancer.
Mm-hmm.
And our guest tonight, I would say more than anyone else, is responsible for changing that and helping so that now there are lots of sex therapists who are unafraid and doing great work and talking with individuals and couples about their sexuality, their sex lives after cancer. And that is Dr. Anne Katz, who is a brilliant sexuality counselor and clinical nurse specialist at cancer care way up in the frozen tundra of northern Winnipeg in Canada, and was inducted into the American Academy of Nursing in 2014 and has written 15 books for healthcare providers and consumers as well on topics. Primarily, her first books were specifically on cancer. Men's sex and cancer, women's sex and cancer. I think I might have them out of order. Very important book on young people, sex and cancer, which even among oncologists, I'm sure doesn't get discussed with any comfort at all, but has broadened it to just the general topic of illness and sexuality. And again, as you said, that impact both of illness on sexuality and sexuality on the body, on the effects, whether we're talking about surgery and changes or chronic illness or acute illness. So we're good timing with talking to Anne as she's coming up on the second edition issue of Women, Cancer, Sex, and her new book on sexuality and illness that'll be out this fall.
Yes. Yeah, I think she said September. So yeah, looking forward to that because there's some really good pieces in there.
So we had a really great chat. So let's
go right to it.
Share it with our peeps.
Indeed.
Dr. Anne Katz. As I said, very, very excited to welcome a dear old friend and a bit of a reunion. It's been way too long since we've had the chance to talk and see each other. Dr. Anne Katz, welcome to Sex Talk.
Good to see you.
So, yeah, you too, and just to see your very familiar faces, and wish that we were together over a table with maybe a glass of something. But yeah, lovely to see you guys.
Yes. You just missed our sake toast. I can't share through the airwaves, but that's our tradition here on Sex Talk. But yeah, like I said in the email, was just, so excited. Of course, been recommending your books to our sex therapy students forever. I've had the pleasure of knowing Dr. Katz since I worked with my late mentor, Dr. Susan Lee, in our first New York Institute back, around 2010, 2009 or 10 when we started, and you've been teaching for us since. And of course, since I know you, I know you for your books on women, sex, and cancer, men, sex, and cancer, excuse me, and young people, sex, and cancer. And then I saw that not only is the second edition of Women, Cancer, Sex coming out, but did you have a new book I didn't know anything about? That's how long we've been out of touch with each other, Sexuality and Illness. So you've gone to the broader umbrella. Congratulations.
Yeah, and that's
Thank you.
brand new one, correct?
Well, yeah, kind of, sort of, not really. So I had actually written a book for consumers on sexuality and illness years and years and years ago. And it occurred to me that because sexuality is affected by, all disease states, PTSD, trauma, you name it, really, it's kind of an A to Z kind of thing. Z is zoster and A is alcoholism or autism or something. And it's really a neglected topic with healthcare providers across the board. Nurses, certainly physicians, very much specialists who, tend to see the organ or the system as their domain, and really, will often neglect quality of life and certainly sexual side effects. So it occurred to me that perhaps instead of educating the consumer, who may or may not be courageous enough to raise this with their healthcare provider, I was going to write a textbook for healthcare providers. So I literally started from the beginning. There actually has been a fair bit of research on the topic in recent years. So I wrote a book for healthcare providers, which I actually just saw the final proofs. And there were a couple of author queries that I had to address. And of course, I found some errors, which just makes me crazy. And this is my least favorite thing to do when writing books. I really, I'm a big thinker in terms of, broad concepts, etc. And I hate the minutia of editing and, correcting and reading every word. So that was a painful process. Yeah. But I did it, and that book comes out in September, middle of September. I, of course, would love to be at meetings, talking about it, and we'll see. Hopefully 2022 will be better.
Nice. And just looking through just some things that I found that just really describe it. One thing that I like right off the bat, and I'm going to be using that textbook myself, because one of the things that really struck me is, we all talk about the impact of illness on sexuality, but you also, if I remember correctly, have a chapter on the impact of sexuality on illness. That it goes in both directions.
Yeah, sure.
And I think not enough people talk about that.
I think things are changing. I'm certainly seeing with, the new young oncologists, for example. So recently graduated people who have gone through medical school, they've gone through a residency, they've done a subspecialty, and perhaps a fellowship. And there certainly is recognition, and they're quite willing to refer. And I think that's the point of it. While, we don't expect necessarily a cardiologist to be an expert in sexuality and sexual dysfunction, etc., they should know enough just to know when they need to refer that person on to someone who does know. And I think it's really important for sex therapists and sexuality counselors to know enough about illness so that when they see somebody who perhaps has, decreased libido, it's not just a question of perhaps looking at it from a psychotherapeutic perspective or from a systems theory. If it's a woman who's experienced body image changes, or she's on medication because she's had breast cancer that we know cause decreased libido, you've got to address the context of the situation. It's always about the context. Where's that person from? What medications are they on? And we live in the world of the internet, and you can always look it up. So I think it behooves, both healthcare providers as well as sex therapists to know just a little bit about what each other are doing.
Yeah. Well, if I remember correctly, you have this center up there in the frozen tundra in Manitoba, in Winnipeg. But there is a kind of coordinated interdisciplinary approach, yeah, where you have the sex savvy urogynecologists and the pelvic floor PT, and that kind of, like we talk about, the dream team.
Mm-hmm. Yeah, that really.
Well, I would. I'd like to think that, I think there are significant gaps still. And people really do. Listen, my physician colleagues are important, make no mistake about it. But I think there is still that focus on where their expertise lies. I've been doing this work in the oncology world for almost 21 years. It's a long time. And it's been, in some ways, a real slow process to be recognized, for this to be on the radar. And certainly it's really rewarding when you get a referral from someone and send them the note back. Certainly we have a really strong pelvic floor physiotherapy practice that I work with really, really closely, and they're an absolutely great help. But sometimes it really does kind of feel like a voice in the wilderness, and which is kind of disappointing in a way. But I also know that, certainly from people like you and other places where I've presented, and, I do a lot of education to nurses and other healthcare providers, really globally. And people are hungry for the knowledge.
Mm-hmm.
Yeah, well, I really do credit you with taking that fear of talking about cancer from so many sex therapists, just in our institutes and in all of the professional organizations that we share, both the sex therapy ones like ASECT and STAR, and the more sexual medicine ones like ISHWISH, and what's the ISM ones, right?
Yeah.
The American and the International Society for the Study of Sexual Medicine. So yeah, we certainly know and do our fair share of bitching on this, our little platform here, about that shouting into the wind feeling.
Yeah.
But times are changing, however slowly. But I did want to ask you this also, because of my knowing you and hearing you lecture as often as I have, it's become part of my thinking as well, and not just professionally, but even like with friends and family when it comes up. And I had one family member who surprised me with her reaction, that said when she was going through cancer treatment, if anybody would have come in and asked her about sexuality, she would have been pissed off and told them to get the fuck out. And it's the only time I've ever heard that kind of reaction. Everybody else seems like that there's such really, we can talk about it and we can ask about it. So I wanted your take on that.
Well, firstly, what's with your relative? Really, I think it's all about timing. I'm not sure. Well, no, I'm pretty sure that when someone is certainly in hospital, in sort of the acute phase of really, just post-surgery, or perhaps while they're having chemotherapy, even as an outpatient, sometimes you catch them on a bad day. And it perhaps is just not relevant for them at that time. What I would like to think is that, one day when this relative of yours was really sort of through to the other side of active treatment, where people do, realize that man, or woman, they survived. And now it's about quality of life. And perhaps there is something missing. And I hear from a lot of women that they feel broken, right? And it is only during that, starting, I guess, with recovery, so there's a difference between active treatment, recovery, which is the immediate period after that, and then moving through what we call survivorship and back into life as they knew it. And that's often when people recognize that, things are different. They're afraid of pain. They're afraid of hurting their partner. That this becomes something that's more acceptable to talk about. Sometimes this really, it should be done at the level of the primary care provider, whether that's a family physician, a gynecologist, a urologist who sees people in follow-up, because often cancer centers, send people back, transition people back to their primary care provider, because there just isn't space, right, and throughput in cancer centers. And, your primary care provider should know a lot about you and the context of your life, which perhaps would make it easier. I certainly, I would probably laugh if somebody told me to get the fuck out of here, because, I've got thick skin, and people have said a lot worse to me. But, I think really it says more about the person than about the question.
Yeah, or I think, as you said too, the timing.
Yeah.
I think something may be a little too soon, and I think that's where we get some pushback, don't we? And I'm sure that you would get some pushback from other physicians, from the standpoint of hey, they have enough to worry about. They've got enough on their plate, so just leave that alone.
Right. And then, often it's that same person who will say, just be glad you're alive. And I think there's nothing that annoys somebody who survived cancer treatment to be told, just be glad you're alive. Because
the same, like you said about the cardiologist, when guys are timidly asking about sex at their 6-week follow-up, and they say, just be grateful. I saved your life. Don't worry about trivial things like that. Or the obstetrician,
or the 3-flight rule.
The obstetrician that says, be grateful you got a healthy baby. What do you mean sex is painful? You got a place to complain. Unfortunately, it's all over.
I've had the unfortunate experience of having to say to a urologist who basically said no to something that I asked about a patient. And my response was to, take a deep breath. And as I get older, I actually care less about what people think about me. It's extraordinarily freeing. So I turned around to him and I said to him, before you say no again, I want you for just 10 seconds to imagine that at your age, you will never have another erection for the whole of your life.
Good for you.
Yeah. And sometimes you have to be that crass and that pushy and, perhaps bitchy. I mean, I take that as a compliment, but
I bet you got a yes out of him though, didn't you?
He thought about it. I mean, he actually thought about it. And the next time he didn't say no.
But that's such an important piece. I mean, how many times we have talked about, and we have even said, that we're constantly reminding medical doctors, especially genital doctors, that there are whole people that are attached to those genitals. And I think that's really such an important orientation that you're able to give a doctor like that. Imagine how they might be experiencing that. And if I can follow that up with, and I know different cancers have different issues for different people, but are there certain kind of common issues that either men or women or anybody else tends to experience when they're going through any kind of cancer treatment?
Absolutely. So for women, the top two are probably loss of libido and body image changes. Then we get dyspareunia or pain with penetration. Those are probably the top, or dysorgasmia, changes, or anorgasmia, changes in orgasm. So those probably are the four for women. For men, erectile dysfunction is number one. Loss of interest, loss of desire, probably number two, or perhaps number three, I would say changes in orgasm. So, pain with orgasm, anorgasmia, or just changes in the quality. It's probably number two or three. And, increasingly I'm seeing body image stuff. And it's interesting to me because I think, the common perception is, men are fine about, don't have body image problems. And that's not true, particularly for younger men. And it comes out in really interesting ways. I remember some years ago talking to a guy in his late 20s, perhaps he was 30. He had colorectal cancer. And, these surgeons are not particularly meticulous when they do cancer surgeries, right? So he had this massive scar on his abdomen, the traditional sort of railroad tracks, and he was gay, and he used to go to the beach wearing a t-shirt, and that was really problematic for him. And he was very well aware of the sort of everyone checking everybody else out, and there he was in a baggy t-shirt. He also said that after his surgery, he lost a lot of weight. And we have a relatively small gay community here in Winnipeg. A lot of men leave and go to Montreal, Vancouver, Toronto. And he said that when he lost weight, he really didn't like to go out at all because he didn't want to be perceived as having HIV.
Yeah.
That's
complicated stuff, right?
Yeah.
And you remind me that it's not just, I think some people may tend to think with sexuality and cancer that we're only talking about prostate cancer or vulva or vaginal or ovarian cancer or testicular cancer, but any cancer, especially you mentioned, colorectal cancer. People don't realize that there's a shared wall there, and that not so gentle surgery, if a woman has something going on with the digestive tract, it's likely going to have effects. But anywhere, like you're just going through chemo and radiation changes the way tissue feels, and it changes the way skin, changes the way the brain perceives touch and arousal, I would think.
Mm-hmm.
Yeah, and patients often complain, and say, why wasn't I told this before? And, there are multiple reasons for that. Often they have been told that, you can expect some changes in your relationship, sort of a euphemistic way of talking about it. And they don't remember because they were told that, really close to when they were told you have cancer. It is often really, certainly, I know, speaking as a nurse, right? We have a checklist in our brain about what we have to talk to patients about. And sexuality and sexual functioning is way down on the bottom of the list, and easy to not include because you're pressed for time. And you're really a little bit embarrassed, and maybe, the patient is the same age as your parent or your grandparent, and they don't have sex, right? So it doesn't get mentioned. And I know from my own experience, I've talked to patients, particularly men with prostate cancer, pre-treatment as part of the decision-making process, which is another thing that I am tasked to do, or part of my job. And I know what I've told them. And I speak to them after the surgery, and they have not a hot clue. They don't remember. Because, being told you have cancer is like a train going through your, is like a train, sorry about that, is like a train going through your head. And it's just a lot of noise. And at that time, all you can think is, am I going to live or am I going to die? And people will bargain away a lot of stuff, even though it, it doesn't help and it's not predictive in any way. But they will say, if I live, I am prepared to not.
Mm-hmm.
There's a whole list, and it's obviously personal for everybody. So, so it's difficult. And you have to be a really good communicator to do this work as the work that you do. It really hinges on communication.
Mm-hmm.
It
Absolutely.
really does.
Yeah, both within and between,
Yeah.
so important. I want to ask you too, how do you help people navigate that process of going from, I guess, having their identity, then having something like cancer or some other illness that then kind of becomes their identity? So it's going from I have cancer to I am cancer. And how do you help people get through to that thrivership and on the other way, get through that intact?
Yeah, I think that's just such a brilliant question. Many years ago, like in the late, really good question.
Okay.
Um, many years ago, so I'm talking, the late 80s, early 90s, I worked in HIV/AIDS. And one of the things that I noticed and always wanted to write about and didn't for a variety of reasons, including getting a master's and PhD, which kind of got in the way. They would say, I am HIV, as in, I am HIV positive, but they would say, I am HIV. And that's something called reification. One of the things that really irks me, I don't want to say irritates because it's not intentional, but something that irks me is when healthcare providers in particular talk about cancer patients, right? Cancer is a noun. It is not an adjective. So it is a person living with cancer. It is somebody being treated for cancer. It's not a cancer patient. And I correct people all the time about this. And I think that applies to someone going through the process.
Definitely.
That it becomes, and I understand why, it becomes their life. And it becomes their identity. Not everybody. And I think, obviously there's a spectrum. There are people who are, deep in denial about their cancer. And, just this week, I spoke to a man who said, well, what if I don't have treatment? And then I have to say, listen, dying of prostate cancer is not pretty. It's a horrible death. And it doesn't make me feel good to say that, and it feels really coercive, but that's that one end of the spectrum. And then there's the other end of the spectrum where someone carries that identity through the rest of their life. And a woman who was treated for breast cancer 25 years ago still regards herself as a cancer patient, sees herself as immunocompromised, even though she may not have had chemotherapy. Now, we can debate whether cancer itself leaves you immunocompromised. I don't think we particularly have an answer for that. Generally, it's the treatment that does that. And other people sort of fit somewhere in between. But as oncology care providers, I think we have a responsibility to really help people move through that transition and somehow let go of that identity. And we don't help, right? Because we see these people over and over and over and over and over again. And they are often scared to leave the cancer center because they think that if we're looking or surveilling or monitoring their cancer, nothing bad is going to happen. And that's absolutely not true. Most recurrences are actually discovered by the person in between visits. So, that's really kind of faulty logic. But, so that's such an interesting question.
And I imagine just what to add on to what you just said too, with that constant obsession, that constant checking, that how can that not reinforce that cancer identity?
Yeah, and it's, I think it's also part of what in the oncology world we call post-traumatic stress symptoms, right? We don't talk about PTSD, we talk about post-traumatic stress symptoms. And part of that is hypervigilance for the combat veteran who has PTSD from, coming close to death. It's hypervigilance about what's going around. For somebody who's had cancer, it's hypervigilance of the body. Any tickle in the throat or the odd pain immediately is, oh, is the cancer back? They don't forget that yesterday they started working out, and went full bore, and they've pulled something, or they just it just hurts. Another thing that sort of really bothers me is the use of the term cancer journey. A journey is where you go somewhere where the destination is appealing. There's choice, there's volition, there's planning, there's anticipation and excitement. Cancer is not a journey by any means. And, we've got to get away from that. And there's a lot of that. There are books and articles, my journey. And, it's hard to criticize somebody who's been through that and has chosen the term. But often the term has sort of almost been put on them because it's part of the common vernacular. It's not necessarily, something that they perhaps thought of themselves.
Well,
Trying to inspire.
Yeah, and I think with a lot of terms that people quote, try to take back. I think for some people, it can be empowering, but for other people, I think it's a setup. I think it could be a trap and hold them back.
Yeah, and there's even talk obviously within certain people within the post-cancer community who don't like the word survivor. They hate the word thriver because they're often left with what we call late or long-term side effects, and things are not the same. And, people will say, I am not thriving, brain fog, which we now call treatment-related cognitive changes. But yeah, we never make it easy, right? Those, the dullness, the difficulty, thinking through things, which I think a lot of us are having with COVID, even if we haven't had COVID itself, because our world has been so changed, I'm losing my words all the time. It is embarrassing. I don't stress about it because it's not going to help. But, I'm talking to a patient, and now I do a lot of my patient visits on the phone because particularly my older patients just can't do Zoom. It's just too much. Sometimes I just see them from like here up because the lid, the lid of the laptop, or they're on the phone and everything's shaking, or they're sitting in front of a window, you can't see their face. It's really quite amusing. And the sort of the confluence of COVID and cancer has been so interesting to me. I was seeing this couple, and I mostly see couples because, if someone's had cancer and there's sexual problems, the partner's involved, certainly in trying to resolve the issue. But I saw this couple, and they were sitting about a foot apart. So I was seeing half of each of them, right? And mostly there's like painting on the wall. And I said to them, do you think you could scooch together a bit? Scooch is a very Canadian word of like shift. Do you think you could scooch together? And they sort of did, but they still left, some daylight in between them. And I said, come on, like, get close to each other. And they looked at me and said, well, but COVID. I said, what about COVID? Well, and this was in about, I think, May or June of last year. So we were just coming out of, that real traumatic period where we didn't know what was going on. And they had not hugged, kissed, had any physical contact for months.
Fear. Giving each other COVID.
Skin hunger, man.
Yep. Something that's so many cancer patients.
Caught ya. Cancer patients?
Oh, yes. I'm sorry.
Gotcha.
People with cancer.
Cancer.
It's so ingrained.
Absolutely. And I've challenged journal editors, and I've challenged my publishers. and certainly, journalists always need to use the least number of words to get the point across. And it's easy, it's easier to say, it's easier to type. Cancer patients, same thing with COVID. COVID doesn't define someone, and I hear it all the time on the news. COVID patients, and they talk about patients who are not even diagnosed, right? So people at risk for COVID, for whatever reason, are suddenly patients. Patients for me is a patient is a person lying in a bed, right? The rest of the time, they're just people, they're individuals, or they're a partner, So, words are important to me, as you could probably tell. And I spend a lot of my time trying to persuade people to perhaps use another term that is more empowering, perhaps, because who on earth wants to be a patient forever?
Right.
That's what Larry
even
saying,
even
becomes
temporary
that mindset.
Yeah. Oh man, you do such good work. It really is. It's so needed.
Well, thank you. This is I'm really very lucky. I've never had a traditional nursing career. I was a registered nurse, working in a medical ward for a very, very brief time, and was then hauled out of that role and had to implement something called the nursing process, which was looking at subjective, objective assessment plan, except that sort of stuff, for a hospital of 800 with 800 beds. And this was in South Africa way back in the early 1980s, where there was no choice. Like, this was not a committee decision. There was no debate. It was, from the 1st of next month, you will all be using the nursing process. And I had to somehow drum this into people's heads who really didn't give a damn. And then when we moved to Canada, I was having babies for the first couple of years, who are now both lovely young adults, and then went into HIV/AIDS care, which was challenging. I would go and pick up my kids at nursery school, and the other mommies would look at me like I had cooties.
Oh yeah.
Oh, there goes the AIDS person, which wasn't necessarily easy. And then I went to work I went to teach at the university, and missed clinical care, missed making a difference. And kind of I worked damn hard into this oncology piece, and then the addition of the sexuality piece, and it's been amazing. Many people my age have retired, and can't see it happening for a while.
Yeah, I think about, retire from what? Talking about sex all day?
Yeah, exactly.
Reasonably cogent sentences together without brain fog and losing words. I'll keep doing this until I can.
Ricky, thank you for that. I've actually never thought of it in terms of that, and I'm going to use that. Full credit to you. It's really cool.
Yeah, it's good. I feel so lucky every day. Like I'm getting something. I'm waiting for the jig to be up. Like, okay, right.
Someone's gonna find out.
Yeah, but it is.
But I think the success of your institute points to the need, right? People are not paying good money and working hard, to get the degrees and the expertise, because no one's going to pay them, right? People are going to pay for their services, and there's a need, and we certainly have an aging population in an ageist society. I used to think that, like, after 40, why bother? Because everything's kind of jiggly and wiggly, I'm really pleased to have been proved wrong on that. But we really do, particularly for women. It's such an interesting thing. How, somewhere around, I think, the age of 40, perhaps, maybe a little older, you become invisible. You are no longer under the male gaze, which in a way is a relief. but it's also kind of different.
Yeah.
You know, because for
fallen late in his career into the subject of sexuality and aging, even like 80s, 90s, and beyond.
Mm-hmm.
Just been
yeah, and you know, the research shows very, very clearly, you know, from see now I've forgotten her, Debbie Herbenek, right?
Yeah.
That and this is big national data, that people in their 70s, 80s, and 90s, you know, are doing stuff. And I always remind myself that when you look at somebody who is 80, they invented sex, right? You know, no, because they were part of the sexual revolution.
Yeah.
Every generation thinks that it invented sex, right? But they really did.
Yeah. He says that to a lot of these hospital administrators that, in 20 years, I'm going to be your patient. You think I'm
Yeah.
going to think about sex anymore?
Oh yeah, that's what actually started this. I was talking with a nursing home administrator. We were talking about some programs and policies, and that's when it really dawned on me. And that's what I did. Is exactly what I looked at. I said, you know what? In 20 years,
Yeah,
right, you're going to have me, and you're not ready.
right.
You are not ready. And I think, and again, I know we can just talk to you all night.
Yeah, we're getting in on our bedtime.
Yeah. So, but on that very point, we can kind of maybe bring this around. We are an aging society. And as we are getting older, we see all illnesses, whether we're talking about dementia. We know that the dementia population is looked at tripling over the next 30 years as we, again, continue to age out. And I can't help but to think that we're going to see a lot more cancer in the population as we continue to move forward. So we all have to learn how to navigate this.
Yeah. And not just cancer. We're going to see a lot of chronic conditions because management of them are so much better. Since people started taking statins, particularly men are living way longer than they used to, because they used to die of a heart attack or a stroke in their early 70s, maybe late 60s. Now, statins have added years to life. The increasing the technology that decreases the invasiveness of surgery, for example. So people don't get post-op infections and sepsis. And for many of us, we're living a really good life. And we're eating well, and we're drinking well, and doing other things. And we're going to be around for a long time. And, certainly cancer is a disease of aging. The vast majority of cancers are diagnosed after the age of 65. And people are living longer with cancer and dying of something else in the meantime. So yeah, the silver tsunami, as they call it, is a coming, and and people are no longer willing to be shuffled off into a room somewhere with a very truncated life. I remember people, my parents' generation, who were my age, right? The age that I am now, and they were old.
Right.
Okay.
Sitting a lot, right? Sitting
a lot, not exercising.
Yeah.
Right. That was not part of life. Maybe they played a bit of tennis or golf on the weekend, but there wasn't daily exercise. And, not as informed as we are, because thank you, Dr. Google, we are not sure where you got your medical degree, but, I had an hour and a half long conversation today with a young man with prostate cancer, with a long list of questions. And, he'd been on social media talking to other men, predominantly in the States, where the healthcare system is really different. And, had a lot of misinformation. And that is often, it's a challenge to try and disinform him of his misinformation.
Well, dear friend, we love you. It's always a pleasure.
Love you too, and this
Can't
has been
wait till
fun.
we can be together next. And hopefully,
Really, hopefully
a
sooner.
conference in Manhattan would be nice, or something.
Yeah,
suitable.
yeah. As they say at the Seder, next year in.
That's right. In Jerusalem.
Yeah,
Or
I'll pass on. I'll pass on that one. But
wherever we can meet, actually.
wherever we can be together.
All right.
Indeed.
Well, thanks
Indeed.
again.
Hey, thanks to you too. Send me a link when this is ready.
Of course, and we'll
Absolutely.
put your contact information in the credits.
Yeah, please do.
So much. So great to see you.
Lovely to see you too.
Thanks. Stay well.
You too. Bye.
All right. Well, we need one more toast for that.
Indeed, yes, I hope she grabbed a glass of wine before hitting the sack. I didn't mean to imply that you're an old lady and had to go to bed, but you said you
It just works
because
hard.
you're at your desk at 6 a.m. We're grateful for you staying up to do the chat with us, and here's to you.
Cheers.
Cheers. Brilliant lady.
Oh, really?
I absolutely
Really.
adore the South African accent. You could listen to her read the phone book.
But
really
her
just-
mind, the way she thinks, the way she's putting this stuff out there, I mean, it really is to use an often used, overused, trivialized term. She's a gift.
Yeah.
She really is, to this field, to the people that she works with, and all of us
And
that have
to-
had a chance to
to me-
learn from her.
To me and us at Modern Sex Therapy Institutes are just so grateful to count Anne among our esteemed faculty, and are just so grateful eternally for your help in, not to sound too corny, but we're kind of forging the next generation of sex therapists, and
Yeah. Yeah.
it's people like you that continue to make these issues, hopefully, at least people realize that it's important to talk about, if it's not necessarily easier to talk about. And
Indeed.
maybe someday urologists will stop lying to guys about all this bullshit, like, oh, we have all these nerve-sparing procedures now, and you won't have to worry about. I
No,
think
there's no
it's
such
kind
thing.
of a safe bet, and I didn't ask Anne about this, but I think she would agree that if a guy has anything done to his prostate, chances are very high that there's going to be some effects, whether it's some incontinence, some erectile dysfunction. Now,
Ejaculatory changes.
I mean, the prostate's like
It's-
everything runs through it,
Yeah.
right? And if
Yeah.
you do surgery on it or even remove it, obviously, one of the trends in urology now is what's called penile rehab, where they start injections or Cialis immediately after surgery, with the thinking that if we can get the blood flowing and get the erections happening as quickly as possible, they'll be less likely to have permanent changes. But as Anne was saying, people need to learn to adapt. It's going to be really hard to stop saying cancer patients.
Yeah.
And remember that cancer is
Yeah.
not an adjective, but people with cancer. And any illness, again, chronic or acute, that forces, look, we're nothing if not adaptable, right? And I used to joke around that, if a guy gets his hands cut off, he'll figure out how to masturbate with his feet. But people need to be creative, especially, and of course, I can't help but put in a plug for sex therapists and the importance of people not only working with their medical team, their oncologists, maybe, again, if we're talking about those kind of urological or gynecological cancers, then their oncologists, their urologists, their gynecologists, and their sex therapists should be part of the team.
Absolutely. And what I would suggest too, because we know through history, our own experiences, as well as a lot of our colleagues, that a lot of medical doctors do not like to talk to us. They don't like to talk to people who are not medical doctors. And part of the reason for that is they just don't understand anything other than what they do. I've heard that many times from physicians. But the patient, the person who is being treated, really is the leader of that treatment team. And if you, as the patient, tell your doctor that you want them to speak to your sex therapist, it'll happen. So patients kind of have to sort of advocate for themselves to bring all of those treatment professionals together so that they can get the best treatment they can possibly get.
Though I would have to say that urologists and gynecologists today seem to be much more, not just open, but they used to be kind of dismissive of sex therapists, like, yeah, we know what you do, whatever. Now more often we're likely to hear, oh, great, give me some cards. I need somebody to send my patients
Yes,
to.
there are.
Because
again,
they don't, they can't answer those questions.
Now, in all honesty, they're still few and far between, but you're right. We are starting to see more of that. And again, as younger people are coming through medical school, there really is a generational thing that's attached to that. Sex and sexuality are looked at a little bit differently in the context of people's lives, I think, by younger people today than by previously.
They're still not getting it in med school, though.
No, they're not. But they're looking for other ways to get it.
Yeah.
Right? And there's promise.
I also, how rare is it that Anne, in that clinical, medical setting, talks to couples?
Yeah.
How often does that happen? Right? If anything, the couple, the partner ends up, by necessity, of course, to some degree, but in that caretaker role, again, without the help of good counseling through that process, too often the caretaker role becomes the parental role, and the sexy is dead.
Right, and it's anti-erotic, absolutely.
So after the illness or the surgery or the cancer, or whatever the issue, it's harder for them to become lovers again.
Yeah.
Right, because they're now in a new, their roles have changed.
And don't let anybody tell you have to make a choice. That it's an either or kind of thing. Right? It's not. You can have all of it. You can have your sexuality, your relationships, and whatever it is that you are going through with your illness. Right? There is a way to balance them, and you can remain a whole person. And I think people have to remember that as well. Right? So with that, that will conclude another edition of Sex Talk with the Siegel Brothers. We thank you all for joining us. Again, please hit that subscribe button, hit the notification button if you want to be informed ahead of time when a new episode is coming out every Friday at 7 o'clock. And hit that like and share button on Facebook as well, in addition to YouTube, and help us continue to grow and continue to have these conversations. So that'll do it for Sex Talk with the Siegel Brothers. Thank you for joining us, and we are out of here until next week. Good night.
Thanks for watching Sex Talk with the Siegel Brothers. Join us each week on Friday at 7 p.m. Eastern. You can also follow us on Facebook and subscribe to our YouTube channel to stay on top of the latest developments in the ever-changing world of sex and sexuality.